Hello, can you hear us?
Yes, I can, loud and clear. Good afternoon. Greetings from AIIMS.
We have expert panel among this hall. We have Dr. Aaron Wong from Singapore, Goran Senkovic from Serbia, and the other two expert panel. And on my left-hand side is Dr. Sunaya from Indonesia.
Nikhil Kumar.
Okay, and Dr.
So
Kumar
we have a
from
great
India.
international panel.
Please introduce your team and your case.
Yes, I will. I have two of my colleagues with me, Dr. Nitish Nayak and Dr. Sandeep Singh. And we have an expert, master of OCT, so-called Dr. G. Dr. Gulio is here, and I think he'll be interpreting the OCT for us. The second case we have will be done by Dr. Jean Fajade, and we have Dr. Ambuj Rai with him. So first, I'd like to show you the case. Can you have the slides, please? Yeah, this is a 52 years old male, non-diabetic, non-hypertensive, non-smoker, dyslipidemic. He had a 3/32 stent in 2013 at another city. Now he has come with class 2 angina on optimal medical therapy. The ECG is normal. The echo functions are normal. Stress test was positive. So we did see the picture. Main to LED, which is
Your sound is not clear.
Can you see the angio?
Yes, I see the angio.
the full frame angio. Full frame angio.
Next one. Next one.
Yeah, you see the next view. It's eccentric lesion, circumflex. You can appreciate this is very tight in iliocranial. As well as in the first view, I have shown you the caudal view. The other view is not well appreciated. I think there is some mild narrowing inside the stent also at the lesion of left main to the LAD. Is it right? Any comments so far? Hello?
So, are you with us?
Are you with us?
Yes, we hear you from our side. We see the osteocircumflex pinching tight stenosis in the osteocircumflex after the stent left main LAD. But we cannot see any disease in the left main LAD.
Yeah, it's a stented artery. There is a mild
Go back.
disease in the
Go back
left
to.
main to LAD,
Go
which
back.
doesn't look angiographically
Go back.
significant. Now our plan is
Go
to
back.
put 2 wires. We have already
one.
just and then do a OCT to better define the lesions and the circumflex. We have an expert and we have recorded this OCT just now and he'll explain you. Over to you, Dr. G.
Okay, it's a crowded lab, so I'm moving.
Wait to OCT now.
Somebody
I'm
needs to
moving
fix
toward
the
the
sound. We
machine.
can't hear him.
So can you hear me? Okay.
Yes, we can hear you.
Okay, perfect. Thank you very much. So we acquire this OCT imaging, having a long pullback of 75 millimeter in 2 seconds. The target we have and why we have run the OCT is to try, number one, to see the expansion of the stent, and secondly, to check the bifurcation and to see which cells were just crossing by the wire. In this case, you show this cartoon upward longitudinal view. That is the automatic lumen detection border. It's telling you about the measurements. While Dr. Bahl is working, we are going to be concentrating a little bit on these measurements. Here you can see the stent. You can see that is fully covered. Here you can see the rendering of the stents. That is showing from where to where is your stent, and is showing if all the struts are nicely opposed. There is no red sign, so this stent was correctly placed. And now we are going to size the stent. So here you can see that the lumen, in terms of mean diameter, is 2.4, while the stent was at 3.0. So this is the first point. Then from the lumen contour, you may see this is the left main. You can see that there is no stent at this point. You are working? And then we are approaching, this is the branch of the circle. You can see the wire going in, and then there is the stent starting. So the points are, number one, where the stent is landing. And here you might see the two wires with a very tight stenosis. This is one wire, this is the second wire. You can see the shadowing. I'm taking out the rendering of the stent, so you can see clearly. This stent is going inside, where there is some stenosis on the distal left main before getting into the stent. And the area is about 5 millimeters square. Then the stent is starting in the left main, and then you have the two shadowing of the two wire. This is the approach of the circle. And in fact, you can see that the cell that was crossed was exactly the distal one. Because immediately afterwards, you can see that you don't have any more access to the branch. Any question?
Any questions about the OCT findings or the different plan?
Is there any question, Dr. Wong? You would like to comment?
I just want to know whether, the stent was intentionally placed in the left main as the previous intervention, or it was sort of incidentally went to the left main?
Actually, yeah.
It was done 2013.
Yes, I don't have the details because it's done in another hospital, another city. What I know is it is a 3x32 stent. But it looks like it is in the left main to LED. Whether they did it intentionally or not, I don't know.
Yep. So there is a stenosis of the osteocirculation is most likely, probably in my feeling, is probably related to the stent placement. Yeah.
Maybe it's not, because he was asymptomatic for 2.5 years. Only he has developed symptom for last 6 months. So maybe there is a recent.
Not immediately, but
Dr. Bahl, I
Yes.
saw from the OCT that there was some smaller stent diameter, maybe because of the stent undersize. And second, can you show from angiogram
Yes.
that there is a significant stenosis? Because we saw from our screen, I couldn't see clearly on the left main
Yeah.
LED except the osseous circumflex. That's Dr. Wong also take note for that.
That's right. That's right. That tight lesion is in the left circumflex. And what is the size you found of the stent, Dr. G?
So it's 254,
2.5. So it's
2.5 in the tightest point.
okay. So do you think we need to dilate the LED stents also?
I think that if you are watching to the OCT, to the
Give a
cartoon,
non-compliant.
you can see that at the level of the bifurcation, there is this type of reduction of the lumen. So I think we might have some supplementary dilation here, even because at this point the stent is, and the lumen is very small.
Okay, can we go back to the angio now? We'll go back to angio now, and now we have 2 wires placed. I dilated it with 2.5 balloon, but now
Before,
this is the
before you
pre-
show
entry.
us, before you show
To
us,
open up the structure.
may I ask our panel for how do they tackle this problem, instant lesion and new
Yes.
side branch? Dr. Goran,
Great.
normally when we tackle left main, we tackle from native disease, not instant restenosis like this, progressive stenosis. How do you approach? Put another stent or just using drug balloon or whatever?
Thank you for that question. You are asking questions that nobody can give you proper answer because ostial circ is the lesion that I think nobody in the world knows what is the best treatment. There are different options, as you said. There are either balloons, new stents, but we don't have enough data. Now he's trying to open his through the strut.
If you notice that when I am inflating the balloon, the waist is still tight, it's not opening. So that means the struts are not yet open.
Yeah, but you cross through the strut, and that's
Could
the
you
reason
just
why.
run that? Yeah, just run. Yeah.
Unfortunately, we
So,
did
but
not see
you
pull
still
back.
notice there is.
Yeah, I'm sorry. I didn't see
Pull back
from the circumflex, so we can really have a better idea now after pre-dilatation. But now you continue working.
Yes, sir.
It's
If you
just
open,
a
yes.
comment. What is the plug
I
distribution and
I
the
thought because. Yeah, but the problem is now the circumflex lesion is too tight, so it has to be tackled.
Yeah, you
And so
already
I thought
pre-dilated.
once
I
have
said
done
after
this,
pre-dilatation.
Okay, if it is open,
But-
we
but-
can cross.
But the problem is I have pre-dilated, but the waist is still persisting. You inflate it, I'll show you again. See, look at the waist of the circumflex. It's still a tight waist. It
Pressures
is
are
at
you
20 atmosphere, 3 NC. It's still
think-
there. Could you notice?
Okay, deflate.
Could you notice that?
Balloon rupture.
Yeah, we can see it, but I think it's just
Yeah.
because you cross through one of the edge cells. Maybe recrossing through another cell by keeping
Maybe.
this wire may help you
Maybe.
open it better.
Maybe.
When you're
Maybe,
doing
maybe.
bifurcations, especially if it's a two-stent strategy, which is what you're going to convert here, you've got to know your stents and your stent design well. Now, we know that the BIOMIME has got 2 cells that are
It
closed
is-
cell in the beginning, and then it goes to open cell. So
Yeah.
you've crossed one of the closed
Yes,
cells, and
yes.
there's no way you're going to be able to dilate that unless you actually go to such high pressures that you
But
break
when
that
we
cell.
yes, when we saw in the OCT, he told that he is going from a
Can you
distal
show?
strut.
Yeah,
Not
may I
from a
ask
proximal
Dr.
strut.
G?
So,
Dr.
looks
G, can you
like-
hear me? Dr. G?
Yeah, he's asking a question to you.
Yeah, because of the OCT technology, could you demonstrate that
Take one more
the
wire.
Y is on the distal strut or not with this the new version of the
Can you
Okay.
demonstrate that wire? Okay.
Okay, let's take the 3D view this way. 3D view. Okay, and go on this way and show where is the wire. So go to the proximal. They are concentrated on the circ.
Just, sir,
Okay.
where it is crossing.
Unfortunately, the struts are covered by the tissue.
Okay.
So it's not easy now to detect the cells. It's not like you have at the implant when you
Okay.
can see the structure
Okay.
because they are covered by the tissue. What we
Okay.
can see,
Yeah.
even in the longitudinal view, is where the wire is coming. You can see immediately before 70,
Yeah.
you can see where the wire is coming through.
Yeah. So is it a good place for wire to, or we should recross it?
Well,
Can you predict from the
but
OCT?
if the question is, can you detect clearly if it is a closed cells or not, that is not the case because we have a tissue growing in two.
Okay.
So it's very difficult to detect the stent design and the stent cells.
So can you now tell, oh no, we have to do another OCT to find out.
So if we can cross with the catheter, we might try to get one pullback
Now
from the circ.
we have tried to recross it. Let's see whether we have gone through another strut.
Okay.
And we are lucky this time. So what I'll do is now to remove the other wire and try through the new wire. Give the same 3.
Can you take a picture on angio?
Yeah,
One
we
second.
can. We can.
What is your plan if you can
Give the
pass
AP.
the wire a little bit distal strut, one strut distal, and if
Yeah.
you dilate, what's
Yeah.
your plan? Put another stent, reverse
Yeah.
culotte or whatever. And I would
If
like
there
to
are-
ask
if
our
I
panel.
can dilate it, there will be 2. Okay.
Proximal.
What is the option panel has? I have 2 options, either doing a tap or doing a reverse cullet.
Dr. Kumar, what's your choice if you are operator of this case?
Yeah, so I think that you already have a stent that if you put in 2 stents, you have multiple layers of metal. So crossing and recrossing require a lot of good hardware and multiple layers of stent. Would you consider a drug-eluting balloon with 1 stent? Any takers on that?
Turn.
Give another new balloon. New balloon.
Okay, here you have the circ. You can see the circ below.
We'll try with the
You
new
can-
balloon.
You
and
can
see.
move just gentle, the rotation. You can see the wire where it's crossing.
Yeah.
You can see clearly.
So-
If they are showing the OCT images,
Just show the OCT image again. He's
Image
showing you the
going
wire
down. you
which
can
stent
see
is
clearly the
going.
wire going through. Move a little bit. Turn the axis. Turn the axis. No, the other side. The other side. Okay, stop. You can see the wire now at this point coming through. It's very difficult to say if it is.
If we are not able to dilate, what
Can you
is the
put the
panel's
stent-
option?
can you put
Should
the
use
stent
the
on?
cutting balloon?
Garan, what's your choice if he could not flare, he could not dilate the strut?
I'm very afraid of using cutting balloon through the struts into the side branch. I was witnessing one occasion that after crossing with
what
cutting
option?
balloon, operator was not able to pull it back. So I think maybe some other non-compliant balloon or another cell, if it is possible. Crossing with cutting, I think
No.
it's potentially risky.
What about a rotablator?
Rotablator, yes.
What about a rotablator?
This is
Can
the
you?
last
No,
resort.
rota is not a choice, I think. With 2 wires.
Aaron, what will you do?
I'll probably try to recross with a favorable cell, but he already pre-dilated with the balloon, so it may have
Go to the
maybe
same
difficult-
route again, right?
Same again, yeah.
Try again.
I think this would be an ideal case
not-
where
it's-
if they had
it's
the
not giving
OPNC balloon that goes to 40 atmospheres, you go with a small OPNC balloon, go to 40
We
atmospheres.
don't have
and you've got
that
a rupture.
balloon available with us.
A smaller NC balloon with higher pressure.
We don't have that balloon with us.
Okay.
So what's next strategy?
When you finish, Dr. Bahl, Shall we
This-
interrogate the vessel?
Oh,
the
high
sea-
pressure,
the
you
circ
know.
by using OCT?
24.
24.
3 NC, 24.
Yeah, one more.
Yeah.
30. Still there.
Is it
Well,
possible to do an
yes.
OCT
No
through the
options.
circ to see, the stent
Yes.
struts?
Okay,
We will do that.
this is
Let
exactly
me
the
try
intention
and
we
open
have.
it up, so if we possible, if not, then we'll. So. Rupture one more balloon and then see.
Now you are back to the left main.
Ruptured again.
I guess maybe it's time to do rotablator
So-
to cut some metal.
Rotablator?
Yeah.
Yes. Why not?
But did you open up the left main? Because in the previous left main LED stand, I guess the stand was not well expanded and too small. I mean, 4.5 millimeter for
Yeah.
left main is too small compared to the very osteo. The osteo
Yes.
left main is a little bit large, maybe
Yes.
5 or 6 square millimeter.
Maybe.
About the wire on the circ is very distant.
Still
You
there.
see, it's not yet opened. Still there.
Okay,
There
shall we
also
try to
must
get
be
down
same.
the catheter and see what
Yeah.
is going on?
Give some.
The OCT?
It's not opened yet.
I think the simplest one is to take another wire and then again keep this wire in position and try to.
I have put. I have changed the wire. Maybe
Yeah.
I can try
Yeah,
again.
but you
There's
were
not an
just
issue.
not lucky 2 times. Maybe the 3rd time you will be successful.
Yeah.
Otherwise,
Third time. Okay. Give one
your-
more wire.
your balloon burst already, so we don't have many options left.
Yes.
Like squirting balloon.
Yes.
Sometimes I find it helpful to put a balloon in the left main and then use a stem boost to see the stent struts in the LED better, so that you know which stent struts to go to. Yeah.
Okay. Okay. We can do that. You have a stent viz in this. Okay. We are
You mean
using
the
a
wire is not
G
in the
machine,
strut
so
that
it
we are
has
going
also-
to open.
Once you pre-dilate it, I think the wire is going to go back into the same path again and again.
Yes.
Get the second wire
I
coming.
agree. Most likely. So I'm trying 3rd time. Let's see what happens. You give a rotator.
You needed to stay very, very distant. Very, very distant, because
Yeah,
there
I'll
is
go to
one,
LED
one,
and-
one additional
Okay.
cells
Okay.
distally to
Okay.
the ones that we
Okay.
crossed before.
Okay. I'll
To
go
go
to
first
LED and
into
then
the
come back
LED
to
and then
position
pull
C.
back from the LED. Don't
Yeah,
go
this is
directly
what
into
I'm-
the.
This is what I'm trying.
We can give you another 4 or 5 minutes before we change to the second room, Dr. Bahl.
Okay. Okay, sure.
Maybe using Zoom, you can see if you are over superimposed or not with the same wire.
Zoom it and see. Okay, let's see. It looks like the same.
Yeah, looks like the same.
Looks like same.
Same side.
I'll try another time.
Shall we change the projection?
Yeah,
The
we
angel
change the
projection.
projection. Aleocranial. Go to aleocranial. Let's see. Just in. Yeah. This will be better. I think it goes.
Different.
Let's take 2.5 or 2.75 NC. Okay. Let's just zoom it. Let's record just without.
Dr.
plain
Damras, have you ever experienced this
Looks
before?
like
Because
same-
for myself,
Looks
I've
the same.
done so many bifurcation, I have not experienced this, that the stent strap won't open. Is it because of the design of the stent?
It's the stent design. The BioMime, it's either the first row or the first two rows, if I remember correct, are closed cell.
Okay.
So every cell is joined, and then you only get the open cell further down.
Okay.
And you can see because they just dropped it so
Give another
with it
NC.
in a way.
What
that
what
is
we have
going
not
through the
used.
closed
No,
cell.
what we have not.
And you have to break that cell, otherwise there's no way you're going to open it up.
Maybe that works.
So,
We will wait you to use the new balloon to open this new Y, and then we go to the second lab.
Oh my God.
For left main bifurcation, this is quite a serious problem for provisional stenting and gel. So if we could consider back, we have to prepare a better strategy to prevent the side branch stenosis. As we know from decay crush or culotte, sometimes it's safe side branch for patency for the next 6 to 12 months. And this, when it happens, it's quite difficult to treat.
We are back. We
Bahl,
tried with
yeah.
another 2-3 balloons. Yeah, we tried with the cutting balloon. We could do it, but it didn't open. So now we have recorded an OCT from the circumflex. Just have a OCT, please. Show the OCT. The problem, I think, is because the struts are the closed struts. This is a BioMime stent which has a hybrid design. So maybe at the ostium, they are closed cell design. So we are not able to open. Now he is over to Dr. G. Show what he's showing.
okay, in the 3D you can see the two wires. This scan was done in the circuit. This is the wire on the circuit, and this is the wire going into the LAD. And here you can see that on the opposite side you have a lot of fibrotic tissue for a few millimeters, and then is growing inside these cells that is, in terms of maximal diameter, after having dilated, redilated with a cutting balloon, is a 256. So it was showing in angel that in fact the lumen is bigger because now is a 256. But it seems that we cannot arrive to expand more these cells around this fibrotic tissue. Here you might see when we are turning the wire going into the LAD, and this very limited, few 4 or 5 millimeters, this very narrow stenosis that is much more what we have, but with an MLD that is around 1 millimeter. And so the point is, if we can open a little bit more with a larger balloon now, and that is the type of information we might have now.
We can put again a 3 millimeter NC.
Okay, we know that now is...
what is the size, 2.5?
Is a 2.56.
So 2.5
as the
NC,
maximum
we'll try
diameter.
again and see if it works.
And you can see the amount of tissue that they are inside these cell struts and protruding inside the origin of the circ. And then you might see that was linked to the stent. And then you might see that the circ is quite clean and clear with quite few pathology. Now you can see some plaques at this point,
NC 2.5
but mainly
हीरो ही पड़ा है वो orange वाला.
is this vessel has a very low involvement in a lesion, except this very early point where you can see inside the stents the tissue, and then protruding gently outside from the 2D images.
So if I ask you a question, how has it helped, the OCT? Has it helped anyway?
Well, In this case, it was very complicated because it's not a fresh stent, but we have a lot of tissue around, so we cannot derive exactly the geometry of the cells. I think that the point is that the space that we were opening in these cells remain very limited, and that is probably linked to the closed cell design.
Any other options from the panel? Hello? On.
Still waiting for you to rotablator to cut some metal.
Okay. That will be offline. I don't have that much of time. We can do that, try that.
Have time.
You have any experience of rotablating in such a segment?
You use rotablator to cut some metal, but in the old day when you use bare metal stent.
Just slow. Slow.
Yeah, but you can't leave it alone.
See, I don't think rota will help, but anyway, because whatever helps in instant restenosis rota, they say is by heating. It's not the cutting the metals, Rota is not cutting that.
But then it's a pretty proximal segment, I mean, you
Samin
can
Sharma
cautiously
did
go
an
and peck
open.
and come back. I think it's feasible. I think it's definitely feasible.
Maybe.
Just another balloon.
No, doing is not an issue whether they'll help or not.
No, go back. Go back with the
We
balloon.
just
Go back.
Go back.
Yes. We have
Do it. Now we take a stent whiz. Take a stent whiz. No, it's not open. See, it doesn't just budge. It just remains the same.
passing.
It's 24. No.
But it's not only the first cells. It's strange. The indentation is after.
Is after that?
Yeah, but we are not seeing too much.
We prepare the
Shall I
rota.
come here?
So you all think rota should be tried?
Yeah, because the problem is with the metal and not with the tissue anymore now.
And what other option?
Yeah. Will metal, you think rota will cut through that metal? No, I don't.
As Goran mentioned, rota should be a last resource. You try a lot of methods, try a lot of devices, try to open the strut,
Yeah.
but it's failed. Is that correct?
Okay, prepare the rota.
I just wonder if you measure FFR and you find 82 or 84.
Okay, is 1 millimeter of diameter. In a vessel that is larger, let me take the media to media of this vessel. Let's go from, is a 386 of media to media, and we have 1.1 millimeter of area. So the FFR can be even also negative, but is a huge vessel with minimal area.
Just show that stent vision. We'll see how it works.
But the tissue inside is not so resistant for making these problems. It's a problem with the cells.
Now we'll take, start. Okay, take it, show what it shows.
We have only another 5 minutes. We will leave you here, and then we go back to Sean, and maybe you can progress tomorrow. Okay? And thank you very much for your nice case, very teaching case of how to deal with side branch and also from closed cell design. Thank you very much. Can we go to Sean Fachaday room?